Howdy, this is Dr. Richard Bernstein with the January 2022 episode of Dr. Bernstein's Diabetes University. Before we begin with questions, I want to remind you that my answers are for the general audience, not necessarily for the writer of the question, because I haven't gotten a full medical history, done a physical exam, etc. So my replies are really educated guesses, and you should really consult with your physician before you proceed with any of the advice I give, because it may be meant for someone totally different who has a different history than you. And I just were unaware of your history. Okay. And I also want to discourage long questions that give a life history, because the listeners are not interested in long questions. Should we be getting B complex shots regularly as type 1 diabetics? If yes, how often I have found in the past has it reduced the quantity of insulin I needed? Thank you. Well, I doubt that vitamin B shots are going to reduce insulin doses. Maybe this person thinks that it did. Maybe it really did. It is possible to overdose on vitamin D and to just take it haphazardly without measuring. I said vitamin D, I meant vitamin B, B12. It's when I suspect a B12 deficiency, as is possible, for example, in people who take chronic use of metformin, I do certain tests. I test for vitamin B12, homocysteine, and methylmalonic acid. I want to have real evidence that B12 levels are too low. There are also suggestive tests such as mean cell volume and so on that would suggest to me that I have to do further testing. I never prescribe B12 without evidence of a B12 deficiency. And that is fairly rare that it really occurs. We all struggle with adrenaline spikes from my young daughter. We're away for the weekend, and it's a super exciting for her, which means a lot of corrections and wanting to see what happens. What are your thoughts on children and adrenaline in the context of kids be kids? Well, one of my principal worries with young children is that most of the young children I treat, I catch early. And because I caught them early and we're controlling blood sugars early on, we're able to prevent or slow further beta cell deterioration or loss of beta cells. And if we can possibly prevent beta cell destruction, we make the person's subsequent life much easier. It's much easier to treat diabetes if you're already making insulin. If you have functioning beta cells, even though there may not be enough of them, to treat diabetes with insulin, endogenous insulin being available is a great boon. So I do everything I can to try to keep blood sugars normal. And if someone is going for an exciting time that raises blood sugar, for example, one of these pleasure parks, or even a ball game, etc., I frequently will prescribe a small dose of propranolol, a beta blocker, that stops the adrenaline spike and in many cases prevents the blood sugar rise. Now, saying kids would be kids and putting a diabetic child in the same ball game as a non-diabetic child invokes the hazard of later on burning out their beta cells. There's no guarantee that we can preserve the beta cells, but I've seen enough cases where I think it's worth trying. So I would either minimize the exciting events, or I try to control the adrenaline spike with, you can consult your pediatrician and ask him if he'd be willing to prescribe a small dose of propranolol, and then you see if it works. One day they do the event without the propranolol, record the blood sugars, and on another day, same event with the propranolol, see what happened. If going to a friend's house creates too much excitement, maybe you might want to try having the friends come to your house, etc. So my tendency is to try to do what I can to preserve beta cells. My daughter's blood sugar is completely flat and steady until she wakes up and then starts to rise. I've given up to 3 to 5 units of Humalog, and she still spikes to 137 before she comes down. What else can we do? Well, this is a common problem. It's likely the dawn phenomenon, which I've discussed before. I experienced the dawn phenomenon myself, and virtually all of my type 1 patients experience it. I have some type 2 diabetics who do not go up overnight, and most of my type 2s are taking small amounts of insulin, and I don't have to play the games with some of the type 2s that I do for myself with regard to the dawn phenomenon. What do I do for me? I'm currently taking Levemir insulin, and I take a small dose. I believe it's 3 units at bedtime, and then I take another 3 units. No, I take 4 units. I take a little bit more at about 5 o'clock in the morning, which is about 3 hours or so before I get up. Might be 4 a.m. in the morning, and that seems to prevent the subsequent spike. For some people, we're obliged to not only give a second dose of the long-acting insulin, like the Levemir that I take, but we take a small dose of regular insulin injected subcutaneously, not intramuscularly, to slowly keep the blood sugar down in the early morning hours. So what I'm suggesting is variation on this trick, the trick of split doses of long-acting insulin and maybe a little bit of regular insulin in the early morning hours. So that means setting an alarm to wake up at 4 or 5 a.m. And I have a lot of people doing that. And here's another situation with a daughter. Whenever my 13-year-old daughter goes to sleepover, her blood sugar spikes up from normal to about 185 overnight and results in a sticky high. She tells me she doesn't eat anything that could cause this. Can you explain this and give any suggestions how to prevent it in the future? I want her to be able to have this fun, normal childhood experience while maintaining normal blood sugars. Well, in her situation, we have another adrenaline spike situation, and it seems only to relate when she's visiting friends. So you might want to get the friends over to your house and see what happens when they're at your house. There's also the possibility that even though she denies eating anything that could make a difference, maybe she's eating something that she thinks makes a difference, that she thinks doesn't make a difference, but indeed it does. And for example, I have one patient whose blood sugars go up whenever he visits his grandmother's house. And the grandmother feeds him what she wants to feed him, in spite of his protests about his blood sugars. So it took me a number of months before I found out that this was going on. So we can't be sure about what might be happening. I am tired of the cholesterol talk after my son's labs. Anything I can give the endo to make them feel better about his numbers and make them realize that he will not need a statin earlier than most people. Well, I can't guarantee that, but I do remind you that in the Framingham study, when they looked at what related to heart attacks and cardiac death in people who were taking statins, they found that there was no relation to reduction of cholesterol or LDL, that the people whose lives were saved had reductions in inflammatory markers like C-reactive protein and a number of others that are suggestive of inflammation. So it seems that statins can reduce inflammation, and it's the inflammatory reduction that makes them of value. And therefore, rather than looking at cholesterol or LDL, perhaps we should be looking at C-reactive protein and other inflammatory markers. But in any event, you might get hold of the very famous article by Gary Taubes, who was the investigative reporter who wrote A Big Fat Lie, which was a book. And he also wrote a very well-researched article that was published in the journal Science about 20 years ago, and a slightly shorter version of that article was published in the New York Times Sunday magazine section. So if you look up Gary Taubes and download his article from the New York Times Sunday magazine section, perhaps your endo would be willing to look at it. It's an interesting article, and it tells how this cholesterol myth was created by manufacturers of sweets and sweet foods. So it's a very interesting story, and once an endo reads this, perhaps if he's open-minded, he can realize that low carbohydrate is going to make a big difference in survival. Could you talk about your experience with having a frozen shoulder, please? Specifically. Okay, this fellow asks a lot of questions about it, but I first noticed it when I just got out of medical school. And somehow I realized it was a complication of diabetes. It was mostly in my right shoulder. Before now that I think about it, I actually saw an orthopedic surgeon about the frozen shoulder when I was still an employee before I went to medical school. And I got injections by the orthopedist, which sent my blood sugar sky high for months and did not improve anything. Once I got out of medical school and had time, things were a little slow as far as my practice went. I visited a physiotherapist who was familiar with frozen shoulder and had seen it in many diabetics, and did trigger point massage. That's deep, painful massage on the little trigger points that he found throughout the tendons and muscles in the vicinity of the shoulder, even over to my neck. And because my right shoulder was worse than my left, and I didn't want to spend a second hour in his office, I dealt only with the right shoulder. The right shoulder got cured after, let's say, 9 months of deep massage treatments. And the left shoulder never got better. The left shoulder was not as painful as the right, and its only problem was it forced me to sleep in certain positions at night where I kept my left arm at my side, and it was uncomfortable sleeping that way. The best way was on my back, but when I was on my back, I had my mouth open and my mouth would get dry. So I made a mistake by not having the left shoulder treated, and when I tried to go back to the same physiotherapist, he was no longer in practice, he had retired. And I've not come across anyone else who knows how to treat frozen shoulder, but I discussed it in a textbook on rehabilitation medicine where I wrote a chapter on diabetic complications. Now, one good way of diagnosing frozen shoulder, it's usually the dominant shoulder, and it can be found by asking the patient to perform internal rotation. That is, taking the arm behind his back and raising the hand along the spine as high as he can. And then we usually compare the dominant side to the non-dominant side, because it's usually worse in the dominant side. And if there's a big difference in how high you could raise, and you could measure it with a ruler, I'll sometimes find 6 inches of difference between the dominant side and the non-dominant side. So that's one easy way for a doctor to make the diagnosis. And then you look for trigger points in the vicinity of the shoulder. That's little spots that are tender to pressure. I have a question about bone density and diabetes, specifically type 1 diabetics. I am wondering if it's high blood sugar that causes low bone density, or that type 1 diabetes has some gene that affects us as well? Well, I have an interesting personal story here too. Many years ago, I had broken my left little finger, still a little crooked. And I took it to the emergency room, which happened to, at that moment, was being the bone doctor in the emergency room, was someone who had been a resident when my wife was a medical student and had taught her, very nice guy. And he did an x-ray of my hand, and the radiologist commented that I had very low bone density in my wrists. At that time, this was actually before I went to medical school, long before, and long before I learned how to control my blood sugars. Years later, I had an imaging study of other parts of my body, but my arms were at my side, and the radiologist commented that the bone density in my wrists was normal. But this was after maybe 20 years of normal blood sugars. So the suggestion, not guaranteed, is that I had low bone density in the days when my blood sugars were elevated and had been elevated for many years. And then years later, after maybe 20, 30 years of normal blood sugars, the bone density had returned. So you can see that a lot of my knowledge is born of personal experience. And personal experience does not always apply to everyone else. Here's another interesting question. How fast should a person eat their meals with macros recommended by you? I assume that macros are the amounts of protein, carbo, and fat that I recommend. And I usually don't recommend specifically on fat, but say whatever comes with a protein. Let's say I have about 40 grams of protein, 15 to 30 grams of fat, and 1 gram of carbohydrate on my plate. How elongated should my meal be? I'm personally someone who likes to shove my food in my mouth as quickly as possible when I'm feeling hungry. Does the answer change for regular human insulin versus rapid acting? Well, first of all, I never use the very rapid acting insulins like Humalog for covering meals, especially for diabetics, because many of them, if not most of them, certainly the long-term diabetics, if they've had elevated blood sugars, they likely have gastroparesis, and their stomach emptying is slow. So what this person might do to try to keep his blood sugar stable would be several things. First of all, not to use the very rapid acting insulins, but stick with regular insulin, which has a time of action closer to the effect of protein on blood sugar, because protein does affect blood sugar. And one thing that I vary with each person, depending upon their post-meal blood sugars, is how long before the meal they get the regular insulin. And depending upon whether they have gastroparesis or not and how severe it is, they in one extreme, someone without gastroparesis, and I find this in a lot of obese type 2 people, they must take the insulin sometimes an hour before eating. In some cases, more than an hour. On the other extreme, some people with severe gastroparesis may have to take regular insulin after the meal. So it's really a matter of trial and error and experimenting. And certainly, it doesn't help to wolf down your meal because that could certainly impair the digestion and can also make the digestion different on different days, depending upon how fast you wolf it down and what you wolf down first, etc., etc. So the time before the meal when you take the shot may be important. And it's all trial and error. And I find that people who eat rapidly tend to have less predictability than those who eat slowly. Now, it happens that I eat slowly, and I have to be very careful because I have to take my shot almost immediately before the meal because of my slow eating. So each person is probably different, and it takes a lot of experimenting. And if you do have gastroparesis, the gastroparesis may also have to be treated, and that's a whole separate story, which we've gone to on a number of our videos. My son was recently diagnosed with type 1 diabetes. We are following your low-carb diet and learning to use insulin in the proper way. Recently he had a surprising episode of severe hypoglycemia. Can you talk a little bit about what the causes might be? Well, in my experience, the most common cause is giving the same shot twice. That is, forgetting that I already took a shot, and I fill the syringe and take another shot, forgetting that I had taken one already. So it usually happens when I get a phone call while I'm filling my syringe or while I'm giving my shot. I get interrupted by the telephone, and then I forget I took the shot. It's rare. Maybe it's once every couple of years, but it certainly has happened that way for me. Other things might be that you took the wrong insulin, that you took a rapid-acting insulin instead of a slow-acting insulin, instead of a basal insulin, etc. But usually it's due to some kind of mistake. I don't live with you, so I can't observe you and tell you what was done wrong, but those are just guesses. We're going to interrupt our questions for a few moments to tell you about a few little tricks that I stumbled upon that might be of value to those who inject insulin. One trick is for those who, like me, have not diluted insulin for various reasons. In the old days, I used to use diluted insulin, and of late, I haven't, maybe because I'm lazy, but I have a substitute for diluted Humalog. I usually advocate Humalog insulin for lowering elevated blood sugars. But my blood sugars are rarely so high that I would need a whole unit of Humalog or even a half unit of Humalog. So what do? Well, I have a substitute for diluted insulin. Regular insulin is half as potent as Humalog. So if I have a slightly elevated blood sugar, let's say my blood sugar is 130, and I know 1 unit of regular will lower me by 60. So I might want to take 3/4 of a unit of regular rather than 3/8 of a unit of Humalog. So I will inject the regular intramuscularly, and that will speed up the regular. It will not be quite as fast as Humalog, but it'll be a lot faster than the regular alone would be. So it is reasonable to inject regular intramuscularly to bring down an elevated blood sugar. Whereas if you have diluted insulin, you could use diluted Humalog, for example. Another little trick that can occur when you're injecting insulin is a problem that can occur if you insert the needle into a vial of insulin and don't get it into the exact center of the vial. You may have noticed that the center of the vial has a little circle around it. You're supposed to go inside that circle. And if you're in a hurry, or if the phone is ringing, you might be in a hurry to stick the needle into the vial and you miss the center. Then if you pull out insulin, you may just get air. Even though the bottle is upside down, the level of the fluid is near the needle, but when you pull, because the vial cap is thicker outside the center than it is at the center, the hole in the needle may be blocked. And when you think you're pulling in insulin, you may be pulling in air from the rear of the syringe. So how do you know if this has happened? Well, it's pretty simple. What I do is I'll draw in more insulin than I need. And here's the syringe. I stuck it in what I thought was the center of the vial, but maybe it wasn't. And what I do is hold my hand over the syringe and push. I don't push all the way, I push part of the way. And if my hand gets wet from the insulin that I've shot out, I know that if there's an air bubble, got rid of the air bubble, and I shot a little bit of insulin onto my hand, made it wet. So I have to wipe the hand off, and I then reset the dose at where it should be, knowing that it's all insulin in there and no air. Next question. I'm a 50-year-old type 1 for 30 years. This guy's a survivor. I notice these blue veins around both my ankles, and they constantly get swollen. Is this a result of uncontrolled blood glucose? Have you seen this in any of your other patients? Well, it sounds like varicose veins, and both diabetics and non-diabetics can get varicose veins. They most commonly occur, well, I shouldn't say most commonly, but they frequently occur in women during or after pregnancy, usually during pregnancy, due to the mass of the fetus pressing on veins that return blood to the heart, and thereby increasing back pressure into the veins, lower veins. You also see it in families. You also see it in obese people who have big bellies that are pressing on the inferior vena cava in their groins, causing back pressure. And there are treatments. At one extreme, you might have surgical stockings that come in different grades, from 15 millimeter compression up to 40 millimeter compression. 40 millimeters are very hard to put on. There's what's called an uniboot, which is a special kind of treated gauze wrap around your leg that helps squeeze the blood back toward your heart every time you take a step. And then there are surgical interventions. We try to avoid the surgical interventions, but sometimes they're of value. Sometimes they inject a sclerosing agent into these varicose veins, and most often they go untreated and don't cause long-term harm. But you should see a vascular disease specialist who would hopefully figure out what solution would be wisest for you. My daughter was diagnosed with type 1 diabetes 6 months ago. Our endocrinologist insists that protein is a free food. Can you explain to her why this is wrong so I can show her the video? Well, I don't think you need an explanation. I think you need a demonstration. I think what you could do, first of all, you should read my book first, so that the insulin and food are all treated in a manner that's going to give you predictable results. And then you give her one meal with protein in it, and whatever insulin dose you figured out is necessary for that meal and has worked in the past. No, I do the reverse. What I would do is this. We'll start from scratch. What can I do to show her the video? Instead of a video, I would recommend a demonstration. You find out how much insulin your daughter needs for a meal, and give her that meal without the protein. Her blood sugar will probably go low. You'll have to do frequent blood sugars, maybe every half hour for 4 hours, maybe more. But you record the blood sugars, and her blood sugar will keep dropping. And you keep correcting it with glucose. And you measure the amount of glucose you give her. So, and I recommend the liquid glucose. So you may find that if she has no protein, after 4 hours, she's used a bottle and a half of liquid glucose, or she's used 6 teaspoons of liquid glucose. You have that recorded, and now her blood sugars are normal. You then do the same thing on another day with her usual protein amount, the same dose of insulin, and you'll see that she won't need the glucose. So, in effect, you've proven that the protein is equivalent to glucose. Granted, it doesn't work as fast, but that the protein does indeed raise blood sugar. Help. I'm gaining weight on my low-carb diet. What am I doing wrong? Well, I have no idea what you're doing wrong. I've found that there are a lot of keto addicts out there who think that low carb means that they have to drink a lot of olive oil or some other oil and should be loading themselves with fat. And it could possibly be that if you're a keto addict, you're eating too much fat. Otherwise, you could investigate exercise. You could investigate eating less food altogether. You might be eating more protein than you need. Without being with you, I can't figure out what it is that you're doing that's causing you to gain weight. I assume you don't want to gain weight. So I really can't be with you to tell you what's going on. But I'm guessing if you're a keto addict that you're swallowing too much fatty oils. Why is the triglyceride HDL ratio important? Well, statistically, the triglyceride HDL ratio in blood tests does correlate, has some correlation with heart disease. The triglyceride independently correlates with heart disease, high triglyceride levels, and low HDL levels. So some doctors look at the ratio. But you should not be ignoring all of the other markers of heart disease, of potential heart disease, such as inflammatory markers. And in my experience, of all the things I've measured that predict heart disease, is the lipoprotein small a. I haven't seen a lot of cases. I think maybe I've seen 4 cases. But in each of those cases, there were new patients who came to me for the first time. Their LP small a's were elevated, and they had, at young ages, already had heart attacks before they even saw me. And the only predictor of heart disease that their blood showed when I drew their bloods, and I draw for a lot of predictors, the only ones that were abnormal were the LP small a. So it's very easy to focus on one or another correlator and still miss something or get a wrong tip. If not splitting Tresiba, when is the most common time to take it, meaning daytime or evening, and why? Well, Tresiba insulin is claimed to last 24 hours. But like the other long-acting insulins, the manufacturers who did studies supposedly demonstrating 24-hour action sort of faked things. They gave people more than basal doses. In other words, they gave them such large doses of insulin that they were forced to eat all day to cover the insulin. That's not basal. Basal means fasting. So here are many insulins that are claimed to be 24-hour insulins when they may work for 18 hours or 16 hours or less. And that applies probably to Tresibas. However, With type 2 diabetics, many of them make enough insulin, let's say overnight, to cover the fasting state, that we only use the Tresiba in the daytime to help them cover the fed state, by giving their beta cells a rest and enabling them to make enough insulin to cover their food. So one trick that we use with type 2 diabetics is frequently giving a small dose of Tresiba on arising in the morning. As far as giving it in split doses, we've already discussed that, and each person is different. It's all trial and error, and I've already explained that. I've been using an insulin pump since the year 2000. I have noticed that following an infusion set change, it takes a while for my body to find the insulin. And this is a common problem. It probably has to do with the fact that at the injection sites, there's usually a lot of scar tissue. Sometimes it's on the surface where you could see it and feel it with your hand, and sometimes it's down below further. And what probably happens, and this is my speculation, is that you're loading up the scar tissue with insulin, and then it's overflowing into some normal tissue where it can be absorbed. And that's the phenomenon that you're describing. It's one of the many reasons that I don't recommend insulin pumps. The scar tissue gets worse and worse over time. And eventually, many people find that the pump's no longer working. And it's really that there's no longer any place left to inject that's not filled with scar tissue. Next question. Does a low carbohydrate, high protein diet affect the protein and lipid metabolism? Well, I should just give one answer to this. A low carbohydrate, high protein diet is what the human race existed on for tens, if not hundreds of thousands of years. It was only since the invention of agriculture and the production of high carbohydrate foods artificially that we became exposed to these high carbohydrate foods. So you don't look at a low carb, high protein diet as doing anything to your metabolism that's any different than what happened in the evolution of humanity. What are some of the initial complications you might see in a type 1 diabetic? Well, I examine, until the COVID epidemic, I should say, I've carefully examined every new patient who comes to see me. I have a standard physical exam, which has a number of tests on it, but I have an 8-page exam just for complications of diabetes. And some of the more common ones that I see early on are RR interval changes, that is autonomic neuropathy, and we even see gastroparesis actually affecting blood sugars after a few years of poorly controlled diabetes. Dry feet, especially dry heels, are very common. The intrinsic minus foot deformity, which is the claw toes that are so universal in diabetics, is very common. And double vision is very common. Now, to detect the double vision, you need a special test that most ophthalmologists are unaware of. I do that test. It involves using a red filter over one eye, and it's unusually common. Frequently, I'll find that a patient may come in with, I test for 9 directions of gaze, up, down, side to side, diagonally, and straight on. And frequently a patient might have double vision, let's say in 7 directions of gaze. And then we really control his blood sugars, and 2 years later, he has it only in 5 directions of gaze. And then you keep repeating it over the course of time, and eventually he has no more double vision. On the other hand, of course, if blood sugars have been poorly controlled, the double vision gets worse. I'm in a large social media group of newly diagnosed parents. All of the parents have been cautioned to not use low-carb diets. But then there are few parents who are all saying that they have read your book and they are posting flat lines and pictures of healthy kids. Can you address these skeptical parents and explain the motivation for your approach? My motivation was very simple. It's kept me alive for 76 years with diabetes. I'm going to be 88 in a few months, and I'm a survivor. Now, I discovered very early on that there was no way I could normalize my blood sugars on a high carbohydrate diet. So just by looking at my blood sugars, which I invented back around 1969, it was very obvious to see the effects of high carbohydrate. And if parents want to give their kids high carbohydrate meals, they should look at other kids who have followed the high carbohydrate for years and see what happens to them. But my motivation was to survive. I think my biggest problem with losing weight is hunger. Do you have any suggestions for foods that I can eat which would generate the most satiety? It really varies with the individual. Protein usually generates the most satiety. I know it does for me. I have some low-carb vegetables with my meals, and also I'll eat a large protein portion. And if I eat my protein portion first, I don't have room for the vegetables. So protein tends to foster satiety. The lady who runs my office, Samantha, had an idea for a patient who is stuck at home because of COVID and is getting bored. And of course, what do many people do when they're bored? They eat. So she suggested that he try sunflower seeds, which he would break open individually. So he would put so much time in to get one little sunflower seed that he might not eat many of them. So people who are bingers or big snackers and whatnot might be able to do well with sunflower seeds, because the effect on blood sugar would exist, but it would be very small. And if they're working so slowly trying to get the seeds out, might be successful. So if you try sunflower seeds, drop us an email, let us know what your experience is. I have about 100 pounds to lose. How long do you think it will take to lose that weight if I am absolutely faithful and do not cheat? I indeed have had some patients who have lost weight following a low carbohydrate diet, and we sometimes have to additionally lower their protein because they may be eating too much of it. But usually what seems to work nicely is a drop of 1 pound per week. Now, I have one patient who I'm treating now who's losing weight very nicely, and he loses, was quite heavy, and he's been losing 2 pounds per week. So I would think that between 1 and 2 pounds are reasonable things to expect. And please don't check your weight every day, because there are natural variations in weight, including water retention. Check it once a week. Do you have patients who went through a COVID infection? If so, what happened with their blood sugars and insulin needs? I have had patients who have had COVID infections, and their insulin needs have gone up very high. They've had a host of symptoms. I've also had patients who have had illness secondary to booster shots, but since the booster shots seem to be keeping people alive, I just have to point out that a small percentage of booster users may get some symptoms, and indeed blood sugars can go up, and they can go up quite high. You have to keep chasing them. I have a young 8-year-old type 1 son. We are looking to put him in sports. He has no favorite sport, so we're thinking of steering him toward a sport that's going to be easy for him to manage in regard to blood sugar. Do you have any suggestions? Yeah, I was able to think of a few. I don't know how he'll take to them. Billiards is not a continuous activity like, say, tennis or basketball, so that would have a minimal effect on blood sugar. Bowling goes in the same ball game. Archery would likewise be a sport that, again, doesn't take a lot of extreme muscular activity. And there's still something associated with sports that can raise blood sugar, and that is anxiety can raise blood sugar. If you're in a competitive sport and you want to win, you might become anxious when you're competing. We've discussed that during this session earlier on, and I'm not going to discuss it again. But those sports are certainly worth trying, and you might be able to think of some additional ones like throwing horseshoes. I remember when I was a kid, there was a game called quoits, where you threw rings around a stick. Okay, some people on social media are really against low carb. I mean, they're very hateful, and there is a strong movement against it. This seems to have psychological issue to me. Surely you must have the same experience and developed some wisdom about why and how to handle these folks. One thing I could think of is to ask them for their continuous glucose monitor profiles. Most people who have continuous glucose monitors keep records on their phones for all the blood sugars over the past month or the past 6 months or whatever, and have curves. And there are many people on low carb diets can show flat curves, and the people on the high carb diets can show widely oscillating curves, which are no good for survival. So ask them to show you their data. Well, thanks for watching our January 2022 session. Be with you again on Wednesday, February 23rd. Look forward to seeing you then. Stay well, and good luck.